Governance of Artificial Intelligence, Week 6, Session 28. This is a course offered by Narsar University of Law in the NPTEL platform. The topic is AI in Indian healthcare. We discussed about the global issues in healthcare in AI, and then we also looked at how different countries are trying to regulate them. What are the major issues which are there in terms of governance of healthcare AI or application of AI in healthcare. In this class, we will look into the specific issues of applying AI in Indian healthcare, what the government is doing, what are the various initiatives, and then why governance in AI in healthcare is very critical for efficient and then better adoption of AI in the Indian healthcare. So AI in Indian healthcare, we look at that in terms of landscape, policy, ethics and governance. According to the KPMG report of 2025, AI is no longer a futuristic concept, it is emerging as a transformative force reshaping care, delivery, management and experience. In India, adoption is still early, often driven by curiosity rather than by full-fledged development. So the current AI applications are in terms of generative AI LLMs, speech recognition, agentic AI, machine learning, robotic process automation, which also includes robotic surgery and other process. The key adaptation barriers are fragmentation of implementation, unclear on return on investment, cultural resistance and then trust gaps, ethical and safety concerns, and then there are of course regulatory compliance gaps. So the domains in which AI is keenly adopted or is put to use are self-care and health management, and then primary care and navigation, hospital operations, post-hospitalization, rehabilitation, remote care and telehealth. So in terms of self-care and health management, there are wearables, mobile apps, then there are vitals that are being monitored. Again, there are personalized nutrition, mental welfare guidance, predictive risk identification. So these includes a whole lot of things which are also done by the individuals on their own individual capacity, but data and then other details being shared through chatbots and other applications. Then in primary care and navigation, we have intelligent symptom triage, early diagnostic support, chronic disease management, seamless coordination across providers. This is again being done in both public sector health as well as in the private sector health. Hospital care and operations are also where AI is being deployed, includes patient onboarding, resource planning, AI imaging, clinical decision support, AI-enabled evidence documentation, and also robotic surgery. Post-hospitalization, personalized recovery via AI agents, virtual reality, augmented reality wearables, remote monitoring, predictive readmission, and then preventive care. Remote telehealth care has become a major important thing in the post-COVID scenario. So there is continuous monitoring from anywhere, intelligent triage for physical visit escalation, where whether the physical visit is required or not is decided using AI tools and other AI support systems. Then remote patient management through AI tools is also possible. Public health policy, we need to look at the predictive epidemiology, particularly in a country like India where the post-COVID scenario, it becomes very critical on account of epidemics and then public health emergencies and crises. Then real-time population health management, particularly when you have different communicable diseases and then other risks. And of course, climate-sensitive disease forecasting is also equally important. So there are at least 25 plus real-world use case documented by KPMG, but then the 25 plus number is an underestimation because there are a whole lot of other applications that are being emerging applications that are not been well documented or not well listed as use case studies. So KPMG says enable, embed and then evolve, or look at clear organizational purposes, governance frameworks and then demonstrate scalability and performance. So the real world case studies include CHESIA India Brain City, where that 15,000 brain CT studies have been done, AI decision support for radiologists in 30 Tier 2 and the Tier 3 facilities, then also reduces the fatigue-driven errors, radiologist retains sign of authority, or the human in the loop still being maintained. Then through SmartN, 15,000 users are empowered for voice-tuned, voice-first platform for blind and visually impaired patients, available in 50 languages, including 10 Indian languages via computer vision and natural language processing. Then there is a TBX, this is national scale deployment done by the Minister of AI with AI support chest X-ray interpretation for tuberculosis screening, extend specialist reach to underserved areas. Then chronic disease management, which is again important which again needs to be integrated with the ABDM, which Ayushman Bharat data management, which we will see later. So AI enabled case navigation and clear early diagnosis system for diabetes, health, hypertension, and then non-communicable diseases via primary care platforms. So what do we need in AI in healthcare? Trust, diversity and inclusion. So India came up with a policy which is released in the AI Impact Summit. It is called a Strategy for AI in Healthcare for India, or called SAHI. SAHI sets out the national framework guidance to enable and then guide responsible integration of AI into India's health system. It recognizes AI as a strategic enabler of health system strengthening, anchored in public interest, trust, and long-term resilience. So these are the 5 key pillars: governance, regulation, and trust, health data, digital infrastructure, workforce, and then institutional capacity, and then change management, research, innovation, evidence gathering generation, and then to have an ecosystem that enables all this. So ecosystem enablement and global leadership. So the time frame of the policy evolution is the 2017 National Health Policy mandated digital health architecture. At that time, AI was in the horizon. It did not become fully integrated into the AI policy system. So 2018, Niti Aayog came up with a document where it said, we look at the various policy options. So national program on AI was documented, was proposed by Niti Aayog in the policy paper. Then 2018 AI for Health All strategy also included healthcare as a major application for democratizing technology for universal health coverage. Then 2018 India proposed national health stack building upon the national health policy into digital health architecture, digital health protocols, and then various platforms are to be built. The National Health Digital Health Mission was launched in 2020 for part of the NHA to commit AI tools for data interoperability, government standards for AI reliability. Then 2026, finally, India came up with the SAHI strategy, which again IIT Kanpur at the Ministry of National Health Authority launched the both validation platform. So from 17 to 2026, in 9 years, India has taken a very progressive policy, progressive national roadmap that takes into account the multi-dimensionals of the needs of a country with 1.4 billion population, also looking at the emerging opportunities and challenges for India in deploying AI in the health policy and strategy, taking into account the evolving framework for health. So both our benchmarking open data platform for health AI has been developed by IIT Kanpur in collaboration with the National Health Authority. It provides a structured mechanism for trusted validating health AI solutions before deployment at scale. So it ensures AI tools used by clinicians are safe, reliable, and validated against real-world parameters. So pre-deployment validation by structured testing mechanism before any health AI solution, and then real-world parameter testing, followed by safety reliability assurance, and then institutional collaboration. So it is a government academia partnership model. The Ayushman Bharat Digital Mission, or ABDM, 860 million plus ABDM accounts are created for citizens. So longitudinal electronic health records for all citizens is the objective. This again contains national registers for healthcare providers, facilities and citizens, consent-based data exchanges architecture, digital health ID for every citizen, health data dictionaries for interoperability standards, payment gateways integrated with healthcare schemes. So AI integration is already underway in TB healthcare, X-ray scanning, disease surveillance, claims management automation for health providers as well as for insurance providers, symptom triage database chatbots, and then diagnostic imaging of AI. So these are the 6 core principles of AI in health, which WHO presented in the AI Impact Summit, anchoring India's AI approach: protect human autonomy, promote well-being, safety and public interest, ensure transparency and explainability, foster responsibility and accountability, ensure inclusiveness and equity, be responsive and sustainable. So the key impacts, takeaways from the key AI Impact Summit are: purpose before technology. True innovation begins with a clear understanding of purpose in AI healthcare, not curiosity or IP. Data diversity is critical. AI should empower, should not replace humans. Duty of care commitment is there as the core of the AI empowerment. Backbone, a capacity investment, and then AI for all is the vision. So India should develop its own indigenous homegrown mission to ensure that AI works for all, every patient in every region, taking into account the diversity and inclusivity needs and then the demands. So the ICMR came up with the governance of AI in healthcare and health research. ICMR section govern 5 talks about governance of AI technology. While the UAI Act proposes first legal framework, India's health policy focuses on integrating the digital health and the establishment of National Digital Health Authority. NHDB 2019 builds upon the electronic health records based upon international standards, data ownership pathways with integrated ethical principle of data anonymization and de-identification. Then the DISHA 2018, which we have seen earlier, it provides for electronic health data accuracy, confidentiality, security, standardization, national and standard state e-health authorities. So software as medical device regulation, we saw this in the earlier also. Medical devices rules 17 have been amended in 2020. Software with medical purpose is now covered. Need to further develop and establish norm for testing and validating SAMD in India. DISHA 2018 proposed a framework for electronic health data privacy, security and interoperability. But right now, no Indian statute formally defines or categorizes conversational AI chatbots as a class. This we will see later as a case study. Regulation of AI technology healthcare is still nascent even in developed countries. So India is facing the same problem which is being faced by every country in the world. So ICMR's 10 core patient-centric ethical principles include autonomy, safety risk minimization, trustworthiness, data privacy, accountability and liability, data quality optimization, accessibility, equity and inclusiveness, collaboration and then validity. So there's a 17-point checklist for biomedical research and healthcare AI submissions. Items 1 to 8 include objectives, technology, funding and conflict of interest, credentials, type of participants, and then participants recruitment methods, risk and management strategy, treatment of the research injuries. So the 17-point checklist includes potential benefits of the AI tool, evidence, validation, accountability, monitoring, data collection, storage, sharing and access, informed consent, right to be forgotten. Right to be forgotten is important because this is emerging as a key principle in AI data governance, where people have the right to ensure that the data which collected once is not repeatedly used when the purpose is served, or data reuse should be limited only when it is really mandated or when it is really needed, so that the earlier collected data of the moment the purpose is used should not be used or should not be used for generating synthetic data also. So the right to be forgotten is critically important for patients, for those who undergo critical care, or for patients who think that the health information once collected can be misused or can be put to use which was not intended earlier. So the moderation human in the loop is also equally important. So having seen these healthcare guidelines, ethical principles, the the government's approach and all, we need to look into how exactly the real world applications are being deployed or being used, and then what are the major critical issues in understanding their application, their usage by various stakeholders vis-a-vis the regulatory gaps. So we are taking into account the AI chatbots that are used in mental health care. So this is a case study done by a policy research think tank based in Delhi called IGAP. So IGAP looked into the AI chatbots in India, mental health care chatbots, and then how people use them. So the intermediary, so right now there is no Indian statute that formally defines or categorizes conversational AI as a distinct class of system. By default, they are either absorbed into intermediate liability framework under the Information Technology Act of 2000, a framework designed for a fundamentally different technology. So the intermediary liability framework of IT Act covers neutral transmission storage of third-party content, Section 17 exists safe harbor transition provision. Logic as intermediary is neither originates nor controls the content. But conversational AI generates its own content, so the logic breaks down here, and no Indian court has resolved this classification question satisfactorily. But the product liability is emerging as an alternative. Academic literature identifies product liability as a more coherent approach because product liability goes beyond the intermediate liability framework, particularly when generative AI generates its own content and there's a two-way discussion, two-way conversation. So it becomes not a question of intermediary but the product and then responsibility for product deployment and then how it is be used by the user as well as by the developer. So if the developer becomes responsible for foundational design choices, or if the foundational design choices point to a certain direction or induces user to engage or to indulge in harmful behavior or drives the user to some sort of a moral complexity behavior or into depression or into feeling of guilt or feeling of helplessness or feeling of depression, then the developer can be held responsible because design itself induces those choices or drives the user towards those choices. So deployer is responsible for configuration marketing and user access. And then the collaboracy principle which says that liability attaches to party best positioned to prevent harm. This again is a principle that emerged from the liability rules that are applicable for liability which emerges in the technology itself. We will not go into details of this collaborative principle in this, but in a later subsequent class, we will look at its application for AI. So section 4.2 identifies the critical gaps as there is no confidentiality obligation. While the DPDP Act framework creates the no confidentiality application equivalent to the one covered by mental health professional. See, when I talk to a mental health professional, there's an ethical commitment, there's a professional commitment, and so confidentiality get ingrained into it. It becomes part and parcel of the professional commitment, and it becomes a core component of the dealings between the mental health provider, either in person or through telephone or through any medium, vis-a-vis the patient or the one who consults. But in the case of this platform is not thereby subject to duties that are attached to a recognized clinical relationship. Because platform is identified as an intermediary, but in the real world, when I interact with a doctor or with a mental health physician or a counselor, there are clear-cut confidentiality obligations which are bound by ethical norms and guidelines. So the confidentiality obligation, non-availability of that is a loophole that could be used by the platform to evade responsibility, particularly in cases where the platform's behavior or the design itself induces or moves the user to some specific directions. And then the consent, when to take the consent. Consent obtained through long form onboarding notices a poor fit for a consent where most sensitive disclosures occur later during distress, crisis, or after formal consent has been completed. Or the consent timing is really a mismatch. It should be taken not on the onboarding process, but it should be taken in a totally different context. Particularly when I approach a chatbot or when I approach an online mental tool empowered by AI, when I am in distress or when I am facing a crisis or I am in a depression or I am in an emotional distress where I want to commit suicide or I want to commit harm either to myself or to others, the consent timing is very crucial, and what is the nature of the consent, how the consent is obtained, how it will be used is also equally important. More important is the emotional data for product optimization. See, the use of the intimate emotional disclosure which happens when I am in a crisis or when the chatbot responds to my crisis situation. How it is being used or the model training, whether it is used for model training or for subsequent improvement of the design is equally important. So the emotional data for product optimization, how to handle it, right now the framework does not directly address this. Or the critical gaps are related to privacy, confidentiality of the emotional data. See, emotional data is the personal data that is of crucial nature, and that has to be handled with all sensitiveness that a counselor or a mental health physician or a doctor would do, or a trained counselor would do. But when I am dealing with a chatbot, or I am dealing online with a AI based tool where it is being treated as an intermediary, or the liability rules and then the consent rules are not clear, that means there is a huge regulatory gap is there. The platforms are offering harmful or medically unsound advice, and then they don't recognize the signs of acute risk which a human will be easy to sensitively approach and then come to immediate solutions and also to prevent further harm. But in some cases, continuous engagement will result in a behavior that will be more going cycling, or it will be something like a going into a scenario where the user is pushed towards taking wrong decisions, or continued engagement does more harm than stopping the engagement at a particular point. Then absent or ineffective signposting allows distress to escalate, or even the chatbot should sign critically that, don't go further, let us stop the conversation, you are in distress mode, continuing to emote like this is not going to be of help to you, is something important. But if the chatbot or the emote tool does not give that signposting or does not give that signal, the user will be in a distress mode further, and then that escalates, or it becomes a vicious cycle where the user knowingly or unknowingly, in most cases unknowingly, is moving towards a critical juncture where he or she takes a totally wrong decision. So the long-term formation of dependency, if the user gets too addicted to these chatbots or the tools repeatedly over a period of month, or every day morning if the user in a bad mood, or if the user has got some relationship issues, or has got some breakup issues, or is in some distressive mood, and then logs into and then starts crying or becomes very emotive, the long-term formation of a dependency is becoming a major thing because it is inducing a behavior that is not a healthy one. So this actually displaces professional help which otherwise the user would go. So when the user becomes either addicted or become totally dependent on that, the risk becomes very severe. But how do we govern such risks? Particularly when the mental health system in India is not easily accessible, then people have cultural, emotional, personal reasons to approach a mental health provider on account of various factors including taboo, hesitant to disclose personal and then private emotional issues, the question of trustworthiness, or people's hesitancy to reach out to people in harm or people in crisis situations. So the practical advisory can do more harm. Emotional trust makes user to rely on AI generated advice on medication, which could be totally unnecessary or could be harmful. Self-diagnosis, which could be misleading. Therapy again could be misleading or totally unnecessary. Again, financial choices, where the user is induced or the user thinks that spending 10,000 or going for a therapy or giving a money is the right choice, but that could be a wrong choice altogether. So the current framework, no existing framework, imposes a standard of accountability, disclosure or escalation for emotionally consequential advice generated by conversational AI or conversational AI as such, particularly through the chatbots or the mental health chatbots which help people when they are in emotional distress or otherwise, is a huge regulatory gap which need to be addressed and which need to be filled also. So WHO talks about safe messaging guidelines. ICMR 2023 ethical guidelines talk about it. Patient-centered principles, which and then each principle correspond to clear gap anchored observed in the practice of the study. Transparency, 2 or 3 platforms study did not disclose their non-human nature. So people are induced whether the chatbot or the tool through which they interact, who is in the other end. Often it could be induced that people may think, or when I am in distress, if I listen to a female voice that seems very sympathetic or of kind nature, I may think that the female voice is really sympathetic, that is of a real human, but it could be synthesized, it could be generated by the system without any human on the other end. But I may be totally misled, I may be misleading myself further by believing that voice into getting into emotional distress and then relying on the sympathetic words or the sympathetic tone, continuing the same thing without even getting to understand that I am being pushed into a situation where I should not lead to at all. So the safety, harmful outputs, and then what happens if they fail during peak crisis situation if the person takes a totally wrong decision like committing a suicide or harms himself or herself or harms others or takes a wrong decision together like taking sleeping pills or simply discontinues the discussion and then goes into depression. So the ethical guidelines are in place, but how to translate this into regulation is the big question. So the problem is no Indian statute imposes a safe messaging compliance on digital platforms or conversational AI, which should be addressed at the earliest. So active harm facilitation, ineffective crisis resource provision, non-identification as non-human, and then fostering user dependency. These are the four categories of failure in conversational AI platforms. But let us also look into one thing. The conversational AI platforms can play havoc not just in mental health. They can also play havoc in other things including financial relationships, in any sort of counseling including educational advice, financial advice, health advice, or advice that are too personal like relationships, sexual matters, matters that go into the in-depth relationship of family and other things. So the failure in conversational AI platforms is a failure not just confined to mental health, but it's a broader failure. But then conversational AI platforms are also emerging as a alternative to the traditional mental health providers in many contexts, particularly for teenagers, people who don't have access, for women, and then particularly for elderly people, and also for people who are otherwise know that they have a specific mental health condition but do not want to reach out to a mental health counselor or a physician on account of various factors. So conversational AI platforms should have more responsibility, should be held more accountable. Their disclosure should be much more meaningful and sensible so that the person knows on which and to whom he is interacting or she is interacting with, and more importantly people should be well aware of the liability responsibility provisions in the sense that they should know that the user dependency or becoming more dependent on the platform, if it is induced with the platform, they should know how to cut it, or the platform itself should indicate that you are becoming more and more dependent. The platform can do this by bringing in a self-designed norm that if the user uses the same platform 3 times or 4 times a day, then when it goes for the fifth time, the platform should say, I am seeing a pattern of you becoming more dependent on me, so I am not going to allow you to have extra conversation now. And then it should trigger a warning that user dependence on the platform is unhealthy for the platform as well as for the user. And then it should suggest better alternatives rather than allowing the user to engage into such conversations frequently over a period of time in the short term or in the long term. Or the responsibility and accountability should be embedded through the design of the platform itself. That is why we need to look at the accountability of the developers as well as the deployers in addition to the responsible behavior which we expect from the users. So, having looked at all this, where exactly AI ethics stands in the Indian healthcare? A scoping review tells us that there are persistent gaps, although there are a lot of positive and good things about the Indian healthcare as when it comes to AI health. And then how do we address these gaps? So this scoping review uses the Prisma SCR frame, a protocol registered as the OSF. OSF is an open source protocol or source where you can design your protocols. But then this is not a third party vetted or ethical committee vetted protocol. So it looked at different documents, looked at different records, and then it synthesized based upon a narrative thematic approach, comparative approach versus tabular formats. So tri-party AI governance framework is based upon DPDP Act, which gives the legal foundation for the data coverage. Then the Niti Aayog's aspirational vision of 2018 provides the aspirational vision. This again is followed by different documents from Niti Aayog's, particularly the one which came last year on use of AI for Vikshit Bharat. Although this document does not refer to it, I would urge you to look at the Niti Aayog's with Vikshit Bharat and AI related documents. They also talk about AI for healthcare. Then the ICMR Healthcare Guidelines of 2023 sector specific moral compass which we had a look into. So the key international governance frameworks include public health and equity of the WHO's advisory, which again is a soft law principle. OECD's Trust with Innovation, again a soft law principle. UNESCO's Human Rights Advisory, again a soft law one. And the binding UUAI Act risk-based regulation. So when it comes to mental health chatbots or systems that offer mental health, we have at least 3 soft law principles that could be translated into binding guidelines or ethical guidelines, and then one AI Act which again looks at them from a risk-based regulation. The challenge here is how do we translate the binding regulation of the UUAI Act, combine them with the WHO's, OECD's and then UNESCO's into a agile framework, regulatory framework for mental health applications or application chatbots and the AI-based systems that are used in mental health conversations, particularly by teenagers, women, elders and others who have access but who do not want to get into the accessing the regular public health or private health mental health system. So these are the core comparative principles, like core principles, how human autonomy is looked into the ICMR 1, WHO 1, OECD 1, UNESCO 1, UAI Act. See, if you look at it, all of them may be talking on very similar terms, but then implementation is the real challenge. For example, privacy, ICMR talks about anonymization, encryption and user control, whereas WHO talks about valid informed consent is required, and then OECD's respect for privacy as core principle. How do we translate this? Through DPDP Act is a major challenge. Privacy protected through life cycle, that is what UNESCO advocates. UAI Act goes further to implement this, aligning with GDPR principles, and then data quality legally required. So if you look at each one of them, accountability, transparency, fairness, equity, safety and then human autonomy, translating these guidelines which are embedded in various soft law into a binding AI Act or similar act is a real challenge, particularly when it comes to chatbots, particularly when it comes to mental health AI applications and also any similar application where the user uses them in critical situations or in situations where ideally speaking, a human to human interaction would be a better option than going through technology mediated communication and counseling. So, how to translate these core principles into either a binding guidelines through AI Acts or regulatory frameworks, or a quasi-binding or frameworks that could be implementable where accountability and then legitimacy are built in. So the report says these are the critical gaps. There's an accountability gap because the DPDP Act is largely silent on the liability for AI-induced harm. Existing Consumer Protection Act and then tort law to black box algorithms, errors remains legally untested because we don't have laws, we don't have case laws either. Shared liability model is a good, but then it's not a legal mandate. So how do we build the shared liability model into a credible, implementable framework is a big challenge. Then the fundamental paradox is public health data is incomplete, non-standardized and then non-digitized. And then AI trained data is inherently biased, and data creates a feedback loop of systematic misdiagnosis against the very populations it should serve. Of course, this is a larger problem which goes beyond governing of simply AI. It's also the problem of how do we integrate data into AI and for public health as well. So the meaningful concern in context of mental health is again a major challenge because the consent standard, free, specific, informed, unconditional, and then more importantly unambiguous, it is difficult to operationalize India's diverse public health settings due to low health digital literacy, linguistic diversity, and then power imbalances. And so far, we have not seen any binding or anything that makes this into a binding commitment. So, the universalism versus situated ethics, international guidelines talking of lofty principles, talking of lofty ideas, and then binding, making them binding, making them contextually sensible, contextually meaningful, implementable is a real challenge. So, directly translationable transportation, ethical comparison, and then ethical thing we are also very difficult. So how do we look into shared ethics in co-design with local communities, addressing collective social fabric and linguistic diversity is a major challenge. But then this should not become an apology or this should not become a alibi for lowering of the standards or saying we are not believing in universal standards, we will have homegrown standards, homegrown ethical principles, which in turn may be very weak ethical principles that are not meaningfully sensible or that do not give control to the users or that do not really empower the citizens and users. So the privacy security provisions again is a major gap. DPDP Act has not been implemented fully. We don't have the privacy board. A lot of things are yet to be done. But when this is done, the privacy and security provisions of India versus the EU Act, this gap could be addressed by bringing in the ICMR principles into core binding regulations. Similarly, we need liability for AI harm, we need algorithmic audits, but so that ICMR recommendations are translated into binding norms and then implementable practices. So the policy recommendations from this ethics review is harmonization via unified health pathway, legally mandated EIA risk management, and then establish India-specific data standards, strategic ethics committees and the data protection board, adopt a cooperative federalism approach so that state as well as the federal governments or different state governments and then the federal health ministries and then other agencies come together so that the healthcare related EIA in India is implemented in a way that everyone cooperates to achieve the shared goals on the agreed principles. So the concern challenge in India's public health context is huge. We need to look into the low health, digital literacy, linguistic diversity, power imbalances, legitimate use loophole that empowers the public health exemption for the state, and then so this is a major issue. Then the timing problem as well as some of the proposed solutions are also given. AI governance framework, the high level principles that are blue but then there are non-binding. DPDP Act is a general legal tool which is actually binding. ICMR guidelines are sectoral thing that could be translated into binding guidelines. UE Act is a highly binding one. So current composite frameworks covers a spectrum, but we don't have a binding legal specificity, ex ante enforcement mechanisms for high risk AI that defines the UE approach. So the path towards regular hybrid governance model, we have discussed about the hybrid governance model in the early system also on how do we govern AI. So the key findings are governance model is philosophically aligned but legally insufficient. There are critical gaps. UE Act as a benchmark, but how do we translate that into India is the big issue. DPDP Act's legitimate use is a public could be a loophole that needs to be addressed to. Data bias is also a great threat. Accountability for AI used harm is a elephant in the room. So far the current regulations do not understand or do not act upon it. Shared model is good but non-binding. So we need a situated ethics approach. So this is the cross-cutting thing across all the documents. AI for equality should be the central. Data quality should be the foundation. Governance lag in the innovation is a major issue. Human in the loop is non-negotiable. Privacy again concerned, we need India specific solutions. Accountability frameworks are totally required now. So we need to build them right now. So the path forward looks on a hybrid governance model. We can borrow certain elements from the UAI Act. We should bring in the situated ethics of the ICMR plus community, and then the risk-based rigor binding should be there. So we need to bring in center plus state cooperative federalism that will ensure that India's path in health applications related to AI are on a hybrid governance principle. So targeted rulemaking is also required. So the conclusion is transformative potential of AI in healthcare can only be realized if it is built on a foundation of trust, ethics and inclusion. So India is uniquely positioned to lead AI for all by adopting Western solutions, but by building its own grounded India scale diversity and then talent. How India can do it, how India will do it is a challenge, but India is again capable of doing it, so that it sets a good example for the world. So these are the references which we used for this. Of course, healthcare in AI has got a lot of other references, and then this is an emerging issue where literature is also fast emerging, a lot of guidelines also are emerging, and then different countries have different norms, different frameworks. So while the picture globally as well as the nationally is emerging and then maturing, this again is an area where a lot of updation, understanding of the developments in terms of technology and regulation is important. So look at this course or look at this session as an introductory one, not as one that is up to date or that one goes deep into each and every aspect. So this will help you to go further, dig further, expand the scope of your understanding, deepen your understanding both in terms of length and breadth, and then the references which we have given here will be able to help you to start and then move towards such an understanding. Thank you.